All right. I think we're going to go and get started. Hello, everyone. Welcome. This is our first joint webinar that we've done in a while. Usually it's one of us living wellness doctors talking about our topic. This time we are introducing our new member of the team, Dr. Alyssa Cooper, which I am so excited to have her on board. Dr. Cooper came to us from Portland. She's doing her first year residency with us. I've got some questions for her, so she'll be able to share a little bit about her experience. And then after we introduce her and hear a little bit more about her, we've got some questions that people have given us ahead of time that we're going to answer. Now, in your window, you should have a chat window. And in the chat window, you can post questions. And then if you have a question that you want to bring up, please just post the question, and then we will get to those questions when we get there. So, Dr. Cooper, tell us a little bit about yourself.
Yeah, so my name is Dr. Alyssa Cooper. I was born and raised on the west coast of Florida, and I grew up spending most of my time outside. There was a mermaid water park down the street from my house, which is unique to Florida in my little town growing up. And I also danced at a studio, so that is, how I spent most of my childhood. I come from a very large Italian loving family, and I'm the first human doctor in my family because my dad's a vet. So had to transition from animals to humans at some point. So I was the one that took that transition.
Did you ever get to shadow him or like work at his office?
Yes. So I remember one like very prominent memory. I was in middle school and a French bulldog was going into labor like on the weekend, and he was like, "Do you want to come in and help?" And I was like, "Yeah." So I went into his office and I helped. He would like pass me because he had to do an emergency C-section on the dog.
Wow.
And so he passed me the little puppies, and I remember like holding them in this cloth. We had to shake them between our legs because he was like, "That's how you help them breathe." And then he had a little incubator at his office. And so we got to put the puppies in the incubator, and it was so great just growing up around that, even though my mom and I had allergies to animals. So we never had cats growing up. We always had, hypoallergenic dogs, but we were in his office a lot. And it was, a great, great experience.
Awesome.
Yeah.
So then you made it to naturopathic school.
Yes. And so my story of getting there is a little complex. So I'll start from, I guess, prior to my undergraduate studies. So since I grew up in Florida, I had no idea what naturopathic medicine was. It was never on my radar when I was younger. I was always interested in medicine growing up as a dancer and just being interested in, I'm bruised and now it's healing, or like I hurt this and now it's healing. Like that's so fascinating. And so I always had this keen interest in the human body. And then when I went to undergraduate, I planned to be on the pre-medical track, and I started taking all of those classes. I majored in psychology because I enjoyed that for fun. And then I was like, okay, I'll do all the pre-med requirements as well. And when I was a freshman in college, my friend told me about a class, and for a whole semester, you study naturopathic medicine, Ayurveda, yoga, Tibetan medicine, and then you go as a class to India at the end to actually see it firsthand. And they were like, "This sounds like you." Because at that time I was into yoga, and I guess just like my philosophy on life kind of aligned. And so I took that class, learned all about naturopathic medicine, went to India, saw these like naturopathic institutes and yoga universities and detox centers, and I was blown away. I was like, what is this medicine that they're hiding in the States? Come to find out, it wasn't hiding in all the States, just not in Florida. And so when I came back, a month later went to visit the two naturopathic medical schools on the West Coast, so up in Seattle and then also in Portland. I didn't have Phoenix on my radar at that time because I grew up in the sun, and I was like, I'm not going to an even place. Yeah. And so I toured both of those schools. I really liked the school in Portland just for its proximity to the city and growing up in the suburbs, I was interested in living in the city. And so after my freshman year, I was like, this is where I'm going. This is what I want to do. I tried to shadow a bunch of holistic medical doctors and get some type of exposure, but it was really hard to find any true naturopathic doctors in Florida. And so I didn't have my first exposure until touring these schools. And then eventually my dreams came true and I went to Portland, and that's where I did my naturopathic training.
Awesome. How are you enjoying your transition from Portland to Phoenix?
I am loving it. So the first 2 years of school, I was like, oh, this rain is not so bad and this gloom, but I was studying every single day, so I didn't have to spend too much time outside. And then the last 2 years of my training, I started to notice the effects of the gloom and the rain, and realized I couldn't stay in Oregon long term and wanted somewhere sunny, but that had a really good scope of practice. And so Arizona met everything that I was looking for. And so when it came around time to look at residencies, I primarily only looked at residencies here and a few in California, because I was ready to, leave Oregon. And,
ready to change the weather?
Yeah.
What conditions are your favorite to treat?
I love anything in the realm of women's health. That was mostly my focus when I was in school. I did the midwifery classes and did some pelvic floor training outside of my regular curriculum, and a lot of just like personal reading and preceptoring in women's health, some in pediatrics as well. So anything from like menstrual irregularities, PCOS, endometriosis, thyroid concerns, anxiety. And now I'm learning a lot about hormone replacement, which I'm very interested in. And since I'm also a new doctor, everything fascinates me. Any condition, I will be excited to learn more and see it and treat it. And yeah.
How has your onboarding experience been with me and been at Living Wellness these last 5 months?
It has been amazing. It's been, I think, the best residency that's out there. So I will say that with confidence. I did some shadowing with Dr. Turner even before the residency interview period, just to see how her practice worked. And I loved it immediately. And over these last 5 months being in person, I have met so many of your amazing patients that just speak so highly of you. It's very rare that someone meets me and doesn't say like, wow, you are learning from like such a great mentor. And I fully agree with them. I've, seen how you treat patients and what like some protocols that you like to use are. I've gotten really familiar with the supplements and the medicinary. And now for the last month, I've transitioned to starting to see my own patients. And it's so great because we talk about those cases like together in detail in between patients, like, oh, this is happening or this is happening. And yeah, it's such a welcoming environment. All the other docs are amazing. So
I love teaching so much, and I love collaborating on cases. Already even with you, there's been a couple of instances where I've got my flow and I've got my normal, and I'm like, oh yeah, I've seen this before. I do this, this, and this. Like I know what I'm doing. I've done this. And then you'll have this idea. You'll be like, hey, what about such and such? And I'll be like, I haven't even thought of that because I've been doing it this way for 15 years. And so I love collaborating, because having another mind, it's like cooking with someone is so much more fun. And the dish ends up having a flavor that you didn't know was going to happen because there's someone else involved in it. So it's been really fun having you, and you're like a sponge. You're so open-minded, and I'm loving teaching you already. And already my patients have given me positive feedback on seeing you. You're attentive, you're caring, you're super responsible, you're awesome at getting everything done. And your patients and my patients, I think, are really going to be lucky to have us as a team, because in a way, you're an extension of me to help me with my patients. And I think that so far it's working so beautifully.
Yeah.
So one of the treatments that you're going to be able to bring to Living Wellness that I have not offered before is pelvic floor therapy. So tell everyone a little bit about what it is and what we could use it for.
Yeah, so pelvic floor therapy is an amazing therapy for both women and men. I primarily have training in pelvic floor therapy for women. And so what it is, it's the pelvic floor is made up of so many muscles that most people don't even know exist. They don't even know that your pelvic floor has all these muscles that connect and ligaments that connect to your bladder and your back and your hips. And so it is a therapy that's really good for any type of pelvic pain, even hip pain, low back pain that could be related to pelvic floor dysfunction, people that have pain with intercourse, pain with their periods, any type of urinary incontinence, whether that's post-childbirth or later in life. And so the techniques used, there's both internal and external work that's done to help release those muscles because those muscles have trigger points. Just like your back has a trigger point, those muscles can have trigger points. And since there's not, a huge focus on the pelvic floor just in society and the shame around women's bodies that's in society, it's an area that tends to be overlooked. And typically you'll see a physical therapist to have pelvic floor therapy done. But what's nice about, a doctor having training or naturopathic doctor having training in it is that we can address your health from every aspect and do pelvic floor therapy instead of just doing pelvic floor therapy. And so typically patients come in weekly or bi-weekly for a few months and we work together closely. And then the hope is to transition that into teaching the patient how to actually release these trigger points and find these trigger points. And, Kegels are not the answer for everyone. Some people, their pelvic floor muscles are too tense already and they don't need to strengthen them. They actually need to relax them, which I think is a big, miscommunication into society that let's all strengthen our pelvic floor when for some people that's the answer, but for some people it's actually the opposite.
Loosen.
So, yeah.
What about incontinence? It's pretty effective for helping with some incontinence issues as well, right?
Yeah. So any type of, urinary incontinence. So if you sneeze and you have, a little dribbling or cough, or even just like throughout the day, that is typically due to weak pelvic floor muscles. So then the training would be on strengthening those. But some people can have incontinence from like overly tight pelvic floor muscles. So it really is so individualized. And that's why a good assessment is necessary to see. It's hard to kind of assess that yourself. You'll really need someone to get that connection there and just make your intuition on your pelvic floor a little more present. So
awesome. Well, I am super excited. I've already actually referred a couple of patients to Dr. Cooper for this treatment. So I'm really excited that this is going to be something that we can now offer. Awesome. Well, we're going to move into the Ask the Doc Q&A. This is actually our first Ask the Doc Q&A. We're going to be doing some more of these some of them will be in webinar format and some of them will also be on Facebook. So like we'll be doing Facebook Lives. We're going to kind of see which one is more popular. So we're going to start out with the questions that we've already collected because I've been asking patients in the office the last 2 weeks for some questions. So we have a few, but those of you on the call, if you want to put a question into the chat box, go ahead and feel free and we can look at what those look like. So the first question we have is, Dr. Cooper, you're gonna ask me?
Yes. So the first question is, what is your approach to treating hypothyroidism?
Very good question. So when I was in school, I was studying hypothyroidism. I was absolutely fascinated by the thyroid. I feel like most of the conditions that we treat are somehow connected to the thyroid. And the more I got better at treating the thyroid, the more I realized if you can get good at treating the thyroid, you're going to get good at treating this vast array of all these conditions associated with the thyroid. One of my mentors said, if you get good at treating the thyroid, you could run your entire practice just on thyroid. And he's really right. Probably 85% of my patients have some sort of a thyroid problem. So with thyroid, I like to look at what else is connected to the thyroid. Is the thyroid connected to the adrenals? And this is an adrenal exhaustion situation where they've been overworked or burnt out or high stress that's caused the adrenals to weaken, and then the thyroid is weakening? Or is it related to the gut, where they've been eating poorly or they've been eating an inflammatory diet and we're dealing with an inflammatory problem that's then weakening the thyroid function? Or is this another hormonal thing, usually menopause? Or is this a female hormone thing that's affecting the thyroid? Menopause and hypothyroid, it is amazing. When you look at the list of symptoms in hypothyroid and the list of symptoms in menopause, there's like a 90% overlap. It is amazing how much they overlap. So my approach to treating hypothyroid is to kind of identify what type of hypothyroid am I treating, or what is the co-owner of the business, because usually there's some other thing connected to the thyroid. So you kind of so you could think of that as like the root cause, or you could think of that as underlying contributing factors. So what else is contributing to the thyroid function? And then that's really where I treat it. If the thyroid is underfunctioning enough that you need medication, I love thyroid medication, and I love all of the thyroid medication. I've used all of it: Armour, NP thyroid, Synthroid, Cytomel, Tyrosint, which is another version of levothyroxine, and then the glandulars like Armour thyroid, NP thyroid, Westheroid. Those are less available right now. So if you have to use a medication, I definitely use a med. But I also try to think of it as the more med we give, the less we will be expecting to restore function. Because if we're going to replace function, we won't be restoring it as much, because there's no need to restore it if you're just going to replace function and give the med. So I try to do both. I'll replace the function if we need to, and then I always try and focus on restoring. And restoring function, you know, in naturopathic medicine, I think that's what sets us apart from conventional medicine, is we have so many things that help to restore function. So if the underlying issue is gut, then we're going to treat the gut. Check for food allergies, change the diet, clean up inflammation in the gut, so that the thyroid is working more efficiently. Or support the adrenals. We have a number of herbs that we can use to help to support adrenal function. Or if we're dealing with menopause, support those hormones, whether you're giving hormone replacement therapy or other herbs that support that hormonal transition into menopause. So there's kind of a long-winded answer, and it's kind of more of a philosophical answer, but my approach to treating hypothyroidism, that would be it. And then you can get into the nitty-gritties. I liked that question, actually, because it made me have to think about, well, what is my approach? Yeah. And so I finally figured it out after 15 years what my approach is. That's it.
Yeah.
So next question is, I get to ask you, Dr. Cooper, speaking of thyroid, and this is kind of a specific question, can you explain thyroid conversion? A lot of people they talk about it, but explain, what does this mean, thyroid conversion?
Yeah, so in the endocrine system, we basically have a waterfall of hormones starting in the brain and then communicating to various glands. And so with thyroid specifically, we have the gland, and we have that releasing the hormone T4. And that is typically like levothyroxine, that's T4. And then in the periphery, we have that converting to T3, which is the active form of thyroid. And so thyroid conversion is referring to that T4 to T3 transition. And it gets a little bit more complicated if you look at the whole cascade. So first, we have the hypothalamus that's releasing TRH, which is typically not talked about as much. And then, so the hypothalamus releases TRH, that communicates with the pituitary gland, which releases TSH. And that's the lab marker that conventionally is used to look at thyroid function. And then that TSH communicates directly with the thyroid gland, which releases T4 in response. And then in the periphery, it's converted into T3. So when conventional docs only look at TSH, they may be missing that conversion piece from T4 to T3. And so that's why we like to look at those as well on labs, because you could have, normal TSH, And then the inability to convert for whatever reason, you know, some of the reasons listed that Dr. Turner said. And so then your T4 and T3 levels may be off. And that's a main reason why we look at them, to see if there is an issue with that conversion once it's released from the thyroid gland itself.
Thyroid conversion is, I think, fascinating. There's actually a long list of things that support conversion, and then there's a long list of things that inhibit conversion. That would be actually a really good, now that we're having this Q&A, I might make a little, one of our images on Facebook. We can make a conversion image, things that support it and things that don't. So that'll be a Dr. Cooper and I project later. We also got a question from somebody. In naturopathic medicine and in school, what are future therapies or treatments being discussed for seniors? That is a great question. And I'm not aware of like treatments coming out. At this point, you know, I think that approaches will change and approaches might shift. But as far as I'm aware, there's no like meds about to be released or anything like that. I do know that generally glandulars are not recommended in the conventional world. They're especially not recommended for seniors because there's a concern that the glandular having active hormone in it is more dangerous for seniors because it could potentially increase heart irregularities and palpitations. So I'm really conservative on my dosages when I'm using glandulars for seniors. But I'm sorry, I don't have a better answer to that question, that there's not any other future therapies or treatments that are coming out that I'm aware of. I'm on the American Endocrine Society. I'm the president for the Endo A&P, and I'm also on a society called the American College of Thyroidology. And I am not aware of stuff coming out. I think at this point, what we have, I mean, mostly what we have works. For the most part, if the thyroid gland doesn't work and we have to replace a hormone, mostly we have what we need, which is the replacement hormone. However, those meds often don't work for people, or the dosage is off, or the ratio is off. I always tell people, if what you're doing does not feel right, then we need to change what we're doing. We've got time for one or two more questions. We're going to try and wrap this up around 3:30. But the next question, I'll let you, Dr. Cooper, ask.
Yes. So the next question we received was, I have high sensitivity CRP. Can you explain what that means?
So CRP stands for C-reactive protein. There's two types of C-reactive protein. There's regular CRP, which is a general marker of inflammation in the body. It's fairly nonspecific. If the person had any inflammation going on, this marker could be elevated. If they recently drank some alcohol, I've had women on their periods that can cause a little inflammation. If they have any sort of an autoimmune disorder like lupus or rheumatoid arthritis or Hashimoto's hypothyroid, any of those conditions could hypothetically raise a CRP. High sensitivity CRP is more specific, and it's generally thought of as a cardiovascular inflammatory marker, meaning if it's elevated, that person might have higher risk of heart attack and stroke. The problem is that there are a number of reasons why CRP might be high, or it might skew that number. So if they're deficient in B12, it could skew that number. If they're deficient in folate, if they have, there's a genetic mutation called the MTHFR mutation. That stands for methyl tetrahydrofolate reductase. It's a tongue twister name. But if you have that mutation, it can skew your CRP. The person could have inflammation in their gut, and that could raise CRP. So generally, we think of it as a marker of inflammation for the cardiovascular system, representing potential risk for heart attack and stroke. So things to lower it, the number one thing we do is essential fatty acids, which are high in fish oil. This is why I give fish oil to 90% of the patients I treat. If they have any other risk factors for heart attack and stroke, that would also be when you'd want to make sure that you lower any inflammation using fish oil. Now, some people have allergies to fish, in which case you have to find a different source of getting those essential fatty acids. So CRP is a hot topic. We could have an entire talk just on CRP.
Yeah, definitely.
And then we've got one more question for you, Dr. Cooper.
Okay.
What is the difference between all of our blood sugar tests? There's glucose and insulin and A1C. So what are the difference between all of those tests?
Yeah, so the first one that's the most simple, I would say, is glucose. So glucose is referring to blood sugar. And so we could have a fasting glucose that we want to measure. We could have a glucose that's taken postprandial, which means after someone eats. And then we could take it just at random times. And so the glucose that we typically are looking at labs comes from the CMP, which is the complete metabolic panel. That is typically done fasting. And so we look at that after someone has been fasting for 10 to 12 hours, and we see what their blood sugar is at that specific point in time. And so that's the main thing about glucose, is that it's one point in time. When people, do the finger pokes and look at their glucose, that's what they're looking at. That can help assess for prediabetes or diabetes depending on the range, but it's typically not the one thing that's used to diagnose it because it can have so much variability. So that moves us on to hemoglobin A1C, and that is looking at the average glucose in the last 3 months. So it's looking at how much, the name is hemoglobin A1C, for how much sugar or glucose is attached to a hemoglobin molecule. And so that is a little more stable over those 3 months. So around the holidays, sometimes we see people's, A1C a few months later is higher than previously because it's an average. And so that is what's typically used to diagnose diabetes and to track diabetes treatment over time. We can also use it to see if someone's in that pre-diabetic range. And it's a nice value because it gives people time to make those changes and then see if those changes are working over a 3-month span instead of having to take their glucose more frequently. And then the third one is insulin, and that more so looks at your glucose conveyor belt. So how well are you able to move that glucose into the cell or mobilize it? And that value is typically taken fasting. It's recommended to do it fasting. And that tends to raise, raises before hemoglobin A1C does. And so if someone has a family history of diabetes and they're concerned about it, and maybe their A1C is normal, but they have high insulin, that could indicate that there's maybe some insulin resistance going on. And then we would work to address that and treat it even more preventatively and proactively than if we just saw an elevated A1C. And so we typically look at all three of those, and we have optimal ranges for all three of them that we like to see patients in and work with them to get towards.
Blood sugar stuff is amazing. It's also one of the it's like one of the foundations for so many chronic diseases. Mm-hmm. So 90% of the time, whatever condition we're treating, even thyroid, we are also looking at blood sugar, because poorly regulated blood sugar is going to affect everything. It affects brain, mood, blood pressure. It affects, even like your hormones, your serotonin and your dopamine. So it's going to affect your neurotransmitters. Blood sugar, it's one of the foundations of optimal health, is to optimize that blood sugar. So one of our favorite things to do, we do a lot of dietary counseling and evaluation. Mm-hmm. So there was our first Q&A. If you guys have extra questions, feel free to email questions into the office and we'll add them to our future Q&As. And we're going to be experimenting between doing Q&As on these webinars, or if we're going to do Facebook Lives or something like that. So we will keep you posted. Thanks for getting our newsletter, and thanks for registering. And we hope you guys are, if you're in Arizona, hopefully you're enjoying this absolutely beautiful weather. Mm-hmm. And enjoy your Friday evening, everyone. Well, wellness wishes to all of you, and happy holidays. Stay safe. Take care.
Everyone. Hope to see you all soon.
Bye.